Rahul, right. So I think I should start with the note saying that this is a marathon teaching session, a virtual teaching session. The marathon, we announced not just a single class, only one on October 2nd. We had to. Hello, am I audible?
Yes, sir. Yes, sir. Yes, sir. Go ahead, sir.
Other than that, we have done a marathon session of teaching, and it has really shown the caliber of Professor Dinkar sir and Professor Prashant, the way they can go on and on and on. And I think we have a lot of things to learn from you both, sir. The dedication, the involvement. I think you have really set an example, very high standards of teaching, and I think it's a eye opener for our students also, that so much of diagnosis we can make if we have a good ultrasound and machine and a few basic skills in ultrasound. And so we started off with anything they say, anything that is well done, well begun is half done. And our Dinakar said started off so well on the first class, and I think the tempo has carried on throughout the end of the class. And today we come to the last day of the teaching lectures, and I'm sure this is not going to be the end. We are going to interact virtually with Professor Dinakar sir. Dinakar sir has promised that he will come down one day, once things settle down here to Chennai, and then again guide us, handhold us in this regarding, the skill of ultrasound. We also realized there's so much to ultrasound. We thought it was only functional echo. There's so much to ultrasound, and now this today's topic, as you see, is going to be ultrasound of the lung, and that is going to almost sort of supplement our X-rays. I agree, X-rays are going to stay, but still, the bedside almost equal to bedside X-ray is our ultrasound, which will be much faster than the bedside X-ray. And that technique today is we are going to learn. And without much delay, I think I'll hand over to Professor Rahat, and I think he'll be teaching. He'll be giving us today's session. And over to you, Prashant sir. You carry on. I
Yes.
don't know much about sir. You can introduce him. Please introduce
Yes.
the today's speaker.
Sir, Dr. Rahul is my very good friend. He's also an extremely good. He's got good teaching skills, and is very passionate about teaching. And he has also been using ultrasound from quite some time. And his motivation and inspiration, we have one guru in common, that is Dinakar sir, who has injected the passion of learning things. So he has also done many talks in our national conference as well on ultrasound lung. So it's going to be really very nice thing how we can diagnose pneumothorax in less than 15 seconds, or you can, to be very precise, 10 seconds. If you're a beginner, maximum 20 seconds. And how you can differentiate between pneumonia versus other conditions, how to adjust ventilator settings with ultrasound, whether we are providing sufficient PEEP or not, how to differentiate TTNB from other causes. So it's going to be very interesting, and it's very simple. Compared to heart, ultrasound lung is a very static structure with pleura, movement of only pleura will be there. Rest everything is static, but it is very useful. And I'm sure today Rahul is going to take a great class, because his slides are always very good. He puts lot of effort in preparing the slides and making it very easy and simple. Without wasting much time, I'll hand over the mic to our friend Dr. Rahul Kadam. He's a consultant neonatologist, and he's one of the director of the Vamshodaya Hospital, which is coming up in Kolar. Dr. Rahul, over to you. Rahul, kindly unmute yourself. Please run the cursor. Yeah. You can start loading your presentation and start the class.
Give me a minute, Prashant. Yeah. Okay. It's there?
No, not it. First, you have to open in the background your presentation. First, minimize the Microsoft window, Microsoft Teams window. Open the presentation. Yeah, it's coming. Yeah, put it in slideshow mode. Yeah.
Yeah, give me a minute. I need to close this. Uh,
Just minimize that. That's all.
it's there.
Yes, it's coming. Yeah. Please start the call. Yeah.
Yeah. So, very good afternoon to one and all. And at the outset, let me thank NNF Tamil Nadu team and Dr. Prashant and my guru, Dr. Dinakara, for giving me this opportunity. As Prashant rightly said, like both of us, we started learning ultrasound, say, a few years back, and we used to do it for our routine purpose. But unless we have not, if we would have not met Dr. Dinakara, we would have not started teaching ultrasound for sure. So, so far we have covered all ultrasounds, and this is the last lecture of the series. And we are going to talk about the basics of lung ultrasound and then common neonatal conditions which we can diagnose with a lung ultrasound. So we know we know like ultrasound is like our bread and butter nowadays in NICU. We use it day in and day out, particularly echoes and neurosonograms. Lung ultrasound was somehow a forbidden zone so far, but nowadays lung ultrasound is also becoming an emerging tool to assess the newborns. So let us, I think it will take some time. Give me a minute. I think I need to. My slides are not moving, just for a minute. It's got stuck. Yeah. Yeah. Fine. It's okay now? Yeah. Can you see my first slide, Prashant?
Everything is moving.
Yeah, okay,
Yes,
fine.
sir. Yes, sir.
So, yeah, okay, fine. So let us see why we need a lung ultrasound or point of care lung ultrasound. We know like lung disease is the most common cause of neonatal respiratory distress, and we always have a diagnostic dilemma because whatever clinical signs we get and chest X-ray, they have low sensitivity and specificity for most of the lung conditions. Again, we know CT and X-ray, they are associated with radiation exposure. They are time consuming. Cities will require a transportation, and we used to do CTs and X-rays for lack of anything better, and that anything better is now point of care lung ultrasound. So lung ultrasound is a dynamic technique. What I mean by it allows for the analysis of lung movement in real time. We can do it bedside, and it allows for a quick diagnosis. You can finish the entire lung ultrasound movement procedure in less than 3 minutes. It avoids irradiation, it's cost effective, and we can do n number of examinations without any harm or without any risk to the baby. That is not the case with X-rays. They are going to cause a lot of radiation exposure. Now, neonates, they have a thin chest wall, small width of thorax, and with lung ultrasound, we can almost visualize the entire surface of lung in case of neonates. If you see, like lung ultrasound has a very good sensitivity and specificity in most of the neonatal lung conditions for the diagnosis. If and its diagnostic accuracy is better than the physical examination what we do and chest X-ray together. Whatever we do, it is better than the chest X-ray and physical examination together. So lung ultrasound alone is superior to X-ray and examination. It also guides us for fluid management. We can do certain therapeutic procedures like thoracocentesis, and it will help us to assess lung recruitment as well. Now, what is the advantage of knowing a point of care lung ultrasound is that we ourselves perform the ultrasound and we interpret it in correlation with the clinical condition. So we are in the better position to understand what is happening in the lungs rather than a radiologist coming and doing without knowing the clinical presentation of the baby. So that's why it is high time that we should learn point of care lung ultrasound. Now, just we have learned lot of basics in previous lectures. I'm just going to touch few basics. We know what is ultrasound. These are very high frequencies which our ears can't hear, and the principle is very simple. Like transducer is going to send the sound waves, and it is going to listen to the returning echoes. And what we see is the interpretation of these echoes on the screen. When we want to learn a lung ultrasound, we should know two physiologic properties of ultrasound before we go ahead. First one is a linear attenuation coefficient. So if you see here, the linear attenuation coefficient of most of the soft tissues and fluids in the body is very less, whereas the linear attenuation coefficient of the bone is very high. So whenever the ultrasound waves are going to hit the bone, they are going to get attenuated. That's why bone is the enemy of the ultrasound. Now look at the second property, what is called as a acoustic impedance. It is nothing but the measure of resistance of particles in a medium to mechanical vibrations. We calculate it by the formula density of the medium and velocity of ultrasound waves in the medium. And this is the acoustic impedance of all the structures in the body. Now you can see here the acoustic impedance of bone is very high, whereas the acoustic impedance of air is very less. Whereas the rest all soft tissues, muscles and all, they have acoustic impedance in between of the high and low. So what is the significance of that? I'll tell you now. So whenever ultrasound beam hits any boundary between the two tissues of different impedances, some of the sound waves, they'll be transmitted across the boundary and few of them are reflected back based on the acoustic impedance of the two media on either side. If the difference in the acoustic media of the difference in the acoustic impedance of two media is greater, more and more waves are going to get reflected back. So to make it simple, what I mean, whenever we have a bone and soft tissue interface, where bone's acoustic impedance is very high and soft tissue's acoustic impedance is low, or wherever we have air and soft tissue interface. Again, here air's acoustic impedance is very low and soft tissue is high. So at these two interfaces, we are going to get a large difference in the acoustic impedance values. And whenever ultrasound waves hit these two interfaces, most of them are going to get reflected back towards the transducer. And for this reason, air and bones, they represent the limitation of usefulness of sonography. And that's why traditionally medical sonography was limited to the organs of the body which are divided of air and bones. That is parenchymatous abdominal organs and heart. That's why we used to do ultrasound of the abdomen, heart, and a brain where we don't have a air and bones in between. Now, these two limitations of the ultrasounds, or I'll say these two properties, where bone has a very high attenuation coefficient and the difference in the acoustic impedances, these two limitations of the ultrasound are actually the cornerstone of lung ultrasound. And how they help in lung ultrasound, we are going to see. Now, anybody knows this picture, I think it will be difficult to mute and talk for everybody. So I'll just continue. So this is the famous painting from the 15th century, Italian painting. This painting depicts something called as a myth of Narcissus. Most of us know that Narcissus was a hunter and he was very beautiful, and he actually felt in the love of his own image. So basically, he's looking down in the water and he can see his own image, and he felt in a love of his own image. So basically, what he felt in love is his mirror image or a artifact. So similarly, lung ultrasound is nothing but the study of artifacts, wherein the pleura the pleura acts as a mirror, and what you see down the pleura in the ultrasound is not the lung per se, but actually the reflection of the chest wall or artifacts. And how it happens, we are going to see now. Now, let us look at the anatomy of the lung. I want you to concentrate on this part. It's very simple. Lung ultrasound is very simple. So, if you see the structures from outside in, we have a skin and subcutaneous tissue. Then we have a pectoralis muscle. These structures, they overlie the ribs, and in between the ribs, we have a intercostal muscle. So we have a skin, subcutaneous tissue, we have a pectoralis muscle, we have ribs, and in between we have intercostal muscles. Now, down we have a pleury or pleural space, which is lined by a parietal pleura and a visceral pleura. And normally there is a very minimal fluid between these two pleurae. Now, from the visceral pleura, lot of septae will go inside the lung, which divide lung into the different lobules. You can see, and these lungs are filled with a air-filled acini or alveoli. So it's very simple. You have a superficial structures. You have a ribs with intercostal muscles in between. Then you have two pleurae with a pleural space in between, and then you have a lung down. Now let us look at the sonoanatomy of the lung. So whenever you want to learn ultrasound, my first uh, advice is always learn anatomy of a healthy organ or a normal organ rather than looking or rather than memorizing different signs and abnormal findings. Can we mute all? I can hear some disturbance, please. Yeah. Now let us look at the sonoanatomy of the healthy lung. Now, as I told you, we have a skin and soft tissue here. We have a pectoralis muscle, you can see nicely. Now, the ultrasound waves, they will penetrate them. They will penetrate them because they have a very low attenuation coefficient, and they will easily go across soft tissues and there won't be any reflection. So you can see the ultrasound waves have crossed skin and soft tissue and they have crossed the pectoralis muscle. Now next layer we have ribs and we have intercostal muscles inside. Now rib is a bone. Remember what I told you, bone has a very high attenuation coefficient. So it is going to block the transmission of the ultrasound waves. It is going to appear bright and it is going to reflect back almost all the ultrasound waves towards the transducer. And what we see down the rib is nothing but a black acoustic shadow of the rib. This is very simple, very easy. So soft tissues, ultrasound waves will come. This next layer you have ribs and muscle in between. Ribs is a bone, it will reflect back the ultrasound waves, and what you see is the acoustic shadow of the ribs. Now in between ribs, you have a intercostal muscles. Again, the ultrasound waves will go through intercostal muscles. Then you have a pleural space with a parietal and visceral pleura. Again, that's a soft tissue. And as I told you, normally in healthy lung, there is very minimal fluid in the pleura and they are in close proximity. So your ultrasound waves are going to cross intercostal muscles, parietal pleura, pleural space, and visceral pleura. So now they have crossed visceral pleura, and now they have reached the lung surface. Now we know in a healthy lung is aerated, so lung is full of air down. So now air in the lung is going to so now you have a air on one side and you have a soft tissues on another side. So the acoustic impedance of two media, the difference is more. So from this interface, the ultrasound waves are going to go back. So this is what we called as a pleural lung surface interface. So it is nothing but a junction of visceral pleura and a aerated lung. So this pleural lung interface is going to reflect the ultrasound waves back, and what we see down is nothing but the artifacts. This is very important. Everybody has to understand this. Then only we can go ahead. It's very simple. I told you, skin, soft tissues, ultrasound waves will reach a bone, which is a rib. It will reflect all the waves back, and you will get a black shadow. It will cause intercostal muscles, parietal pleura, pleural space, healthy lung we are talking about, and visceral pleura, and we'll come to the lung surface. Lung is full of the air. You have air on one side, you have a soft tissue on another side. Acoustic impedance difference is more. Ultrasound waves are going to go back, and you're going to get artifacts. So that's why lung ultrasound is nothing but a study of artifacts where lung is predominantly aerated. And the amount of artifacts we are going to get, they are going to depend on the relative amount of air and fluid in the lung. What I mean by this, the structures of pleura in air-filled lung cannot be visualized, and what we see are actually artifacts. And when lung is highly fluid filled, in that case, your ultrasound waves are going to cross in the lung as well, and then you can see the lung structures directly. So that's why predominantly lung ultrasound is a study of artifacts. Now with this basic knowledge, let us see how we are going to perform a lung ultrasound. So we'll see indications, which probe to use, what is the procedure, which modes, what sequence, and then we'll see how normal lung looks like, a diseased lung, and some protocols. Now, what are the indications for initial point of care lung ultrasound exam? So you have any baby admitted with a respiratory distress, you have any prenatal suspicion of a lung lesion, if neonate has a sudden deterioration of a respiratory status, or if you want to perform any USG guided procedure, you are going to do point of care lung ultrasound. What are the indications for a follow-up point of care lung ultrasound? It will help us you to guide the respiratory support, to determine the need of surfactant, to guide the changes in the level of respiratory support after surfactant delivery, monitoring the progress of respiratory illness whenever required. You can follow the improvement after thoracocentesis, and it can guide you for a fluid management. So these are the indications of lung ultrasound. Now probe, any universal probe can be used. You should not say like I have this machine, that machine. Whatever probe is available, you can do the lung ultrasound. Ideally, most of the times linear probe more than 10 megahertz is used. Curvilinear probe is a good all-round lung ultrasound probe. It is usually better for visualizations of effusions, consolidation, and diaphragm. Now, coming to the neonates, they have a relatively thin chest wall and small thorax. So here we are going to use high frequency linear probe. All of you have seen. Again, Dr. Dinkar will show afterwards. And frequency, as I said, it should be more than 10 megahertz. You need to disinfect the probe before and after patient examination to avoid any nosocomial infection. You need to warm your hands. You need to use warm gel. You need to swaddle the babies. These all things go by default. I know this thing must have been covered. So patient safety comes before any procedure. Now coming to the procedure, you can set lung preset on the ultrasound machine. Most of the advanced ultrasound machines have lung preset. If it is not there, you can set ultrasound abdomen preset as well. Then your transducer, you can see your transducer, it should be in the sagittal or longitudinal plane with a orientation marking facing cephal head, that is towards the face. So you can see here, I'm going to talk about zones later on. You can see the zone 1, 2, and 3 and how we have placed the transducer. It is in the longitudinal plane. There is my cursor. Your orientation marker is facing cephal head. Probe, you have to hold exactly perpendicular to the chest wall. The sound waves, they should encounter the pleural lung surface at perpendicular angle so that you can get the artifacts. And you must have heard of these terms in echoes and neurosonogram like fanning, angling, sweeping, and all. You don't have to do anything of this sort here. That's why lung ultrasound is very easy. If you do all these things over here, it is going to be counterproductive and you are not going to get a good image. Mute all. Then initial scanning we should perform at the maximum depth to get a global view, and then you adjust the depth based on your area of interest. so that the area of interest comes at the center of the image. You can adjust the gain to optimize the image quality. You know gain, depth and all things. So usually in ultrasound, you need to reduce the gain to get a better image quality, particularly the lung slide or pleural line, what I will talk later on. You will appreciate that better if you reduce the gain. And other thing, most important, you should not add your own movements to the probe. You have to hold probe firmly but gently. You should not keep on moving once you place it. Now, as I said, in neonates, most of the times we perform a longitudinal scan where you're going to keep your probe perpendicular like this with the orientation marker facing capillary, but you can do an oblique scan as well where you're going to put a probe like this. So most of my images will be of a longitudinal scan. Now, just to show you a difference between the images, there is not much of difference in the images of longitudinal oblique scan. I'm going to speak about all the structures later. These are ribs and this is a pleural line. In longitudinal scan, it will be a bit at a lower plane than ribs, whereas in oblique scan, all three of them will be in one plane. Now, which modes we are going to use? Very simple, B mode, M mode, and in very particular conditions, you need to use a Doppler, or most of the lung ultrasound is done with a B mode and M mode. You need to get natural images. You need to avoid any kind of filters like compound imaging, speckle reduction, no filters. You need to get to natural images, no sweeps and all things, B mode, M mode, and Doppler. Now, do you need to follow any sequence? So ideally, lung ultrasound you should do in a systematic manner so that you cover entire anterior, lateral, and the posterior aspect of the lung on both sides. And you can do it in a supine, lateral, or prone position in neonates as well. Now, most of the times we use a 4-point scan. This was proposed in the adults. Same thing we adapt in the newborns. Here there are 3 lines. One is a parasternal line, then you have an anterior axillary line, and then you have a posterior axillary line, and then you have an arbitrary line at the level of nipple, which is going to divide lung into 4 areas. So this we call it as a upper anterior, this is lower anterior, this is upper lateral, this is basal lateral. So 4-point scan, which we usually perform in the newborn. Then 6-point scan is nothing but the extension of a 4-point scan, where you have a zone 1 anterior to the anterior axillary line, zone 2 between anterior axillary line and posterior axillary line, and zone 3 between the posterior axillary line and the spine. And then you have a upper anterior, lower anterior, upper lateral, basal lateral, upper posterior, and lower posterior. A blue protocol is something which is followed in adults. I'm just going to explain it because there's one particular point which is important for us. So here, what we do, we apply the hand of examiner to the patient's chest, and you should compare your hand with the patient's hand. It should be ideally of the same size. It is applied in this way, such that parallel to the chest, such that your upper hand is parallel to the lower border of the clavicle, and your little finger is touching the lower border of clavicle, and your middle fingers, your tip of the fingers, they're touching the midline. And lower hand you apply just below the upper hand. Thumb is not counted. See, like thumb is hidden like this. Thumb is hidden like this. Yeah. So this is called as upper blue hand. This is called as the lower blue hand. And then there are 2 points which we need to define. One is the upper blue point and second is the lower blue point. So upper blue point is nothing but the junction at the base of 3rd and 4th finger with the dorsum or with the palm, and lower blue hand is nothing but the midpoint of the dorsum of the lower hand. So usually this lower blue point is lateral so that we can avoid heart on left side. Now the lower border of the lower hand is what we call it as a phrenic line, and this line where it meets the anterior axillary line is called as a phrenic point, where usually you can visualize the diaphragm. So so we saw upper blue point, lower blue point, and then we saw a phrenic point. And then there is something called the Plapp's point. This is very important. Plapp's point is nothing but posterolateral alveolo-pleural syndrome point. So we just have to. It is just. Hello. It is just a horizontal extension of the lower blue point till the posterior axillary line. So it is a horizontal extension of lower blue point till the posterior axillary line. So that's what we call it as a PLAPS point. You can see here how the transducer is placed. Again, it is placed in a longitudinal plane with a cursor cephal head. You can even go more posterior to the posterior axillary line. Now, we usually can't apply this in newborns, so we need to make a rough adaptations. In newborn also, we need to see the PLAPS point and if possible a phrenic point. So we need to do rough adaptations to get a good image. So approximately we can go in a say nipple line or a bit down the nipple, we can go posteriorly, and wherever we meet a posterior axillary line, that is the PLAPS point. It comes with the experience. You just put probe there and you are going to get a PLAPS point. So ideal neonatal exam. What is an ideal neonatal exam? So usually it is most of the times newborns are lying supine, and most of them they are sick, and it will be difficult to turn them prone or on one side. So at least a 4-point scan on either side, 4-point scan on either side, upper anterior, lower anterior, upper lateral, basal lateral, then PLAPS point on either side, and a phrenic point to see the diaphragm movements on either side. So in newborns, you have to do at least 12 points examination, and that is what we call it as a complete neonatal ultrasound examination. It is not that you just put a probe here and your neonatal ultrasound of lung is done. You have to do ultrasound at this 12 points. Now, with this knowledge, we'll move ahead with the what are the normal signs we see in the lung ultrasound. So this is a list. I'm not going into the list. We'll see them one by one. So the first sign is a pleural line. So this is very important sign. I will show you how it appears. So it is nothing but a thin, smooth, regular, curvilinear, hyperechogenic. All words are important. Thin, smooth, regular, curvilinear, hyperechogenic line. Usually thickness is less than 0.5 millimeter. This is the most bright structure in the lung ultrasound. It is nothing but the echo-reflection of the pleural lung surface interface. I showed you a pleural lung surface interface, so visceral pleura and a lung surface from where the ultrasound waves are going to get reflected back, and that echo-reflection is a pleural line. So usually in adults it is bit below the rib line, but in newborns it is almost in the same proportion. In a normal lung, pleural line represents a visceral pleura. What I mean by when parietal and visceral pleura are in contact with a little fluid in between, when there is no pathology, the pleural line represents the visceral pleura. But when both pleura are separated by some pathology, let it be air or a fluid, then the pleural line represents a parietal pleura. This is very important. Okay, so normal lung, it's a visceral pleura. Whenever pleurae are separated, it's a parietal pleura. And the most important point is all the lung signs, they arise from a pleural line. That's why you should understand what is a pleural line. Once you know pleural line, then you are going to know how other signs come. So this is just the image to show you. So this is the oblique plane. You can see a pleural line. In Dinakar sir's words, pleura should be thin, slim, slender, and beautiful. Thin, slim, slender, and beautiful. It should not be lumpy bumpy. It should be thin like this. So this is a oblique plane, and this is a longitudinal plane. Just to show you structures we have already seen. So you can see a skin, you can see a subcutaneous tissue. Very nicely you can see all layers from the top, the skin, subcutaneous tissue. Then this is a pectoralis muscle, and then this is an intercostal muscle between the ribs. There is one rib, sorry. There's a one rib here, there's another rib here. You can see the acoustic shot of the rib, and this is the pleural line. So the brightest structure on the lung ultrasound is a pleural line, and then down you have a lung or whatever artifact you are going to see. So I think pleural line is clear. So this is a pleural line. So you can see here in the oblique plane, don't concentrate on anything else. I just want you to see the pleural line. You can see the pleural line here nicely. So this is the brightest structure on the lung ultrasound. These are all the superficial structures, whatever I told you, like skin, superficial subcutaneous tissue, pectoralis muscle, then intercostals, and then you have a pleural line. So this is a pleural line. Similarly, okay, again structures you can see skin, subcutaneous tissue, pectoralis, and intercostal, and this is a longitudinal scan. So again, you see the brightest structure is the pleural line. Forget about rest all things down. I just want you to see the pleural line. So you can see the superficial structures here, and this is a pleural line, which is a thin, bright. So this is how a plural line appears. So I think everybody is clear about it. So now we have seen a plural line. So next sign what we need to see is A lines. So A lines are horizontal, hyperechogenic, equidistant lines distal to the pleural lines. They are horizontal, hyperechoic, equidistant lines distant to the pleural line. They are nothing but reverberation artifact. I am going to explain what is a reverberation artifact, and they occur at a standardized distance, that is the distance between skin and a pleural line distance. That is also I am going to explain you. So now, what is a reverberation artifact? So basically, when ultrasound beam encounters two strong parallel reflectors, the ultrasound beam is going to get trapped in these two reflectors, and it is going to bounce back and forth between these two reflectors. That is what we call as a reverberation. And the transducer interprets the sound waves returning as a deeper structures, since it takes more time for waves to return to the transducer. So you can see here, now this is your transducer, this is say transducer skin, and this is a pleural line. You have two strong parallel reflectors, and the ultrasound waves, they are going to reverberate to and fro between these transducers. Now see, this is a transducer, it is going to send the ultrasound waves. So when they come to the pleural lung interface, what you are going to get is a pleural line, and I mean from here they'll go back, and what is interpreted as a echo of a pleural lung interface, and you're going to get a pleural line. So till pleural line it is clear. Now what happens, this ultrasound waves are going to come back again, and they're from here they're going to go back again. So that is going to cause the another reflection down the pleural line, that is first A line. Again from here it comes back and goes back, and that is going to cause your second A line. So because of this reverberation of the ultrasound waves between transducer and pleural line, you are going to get hyperechogenic, equidistant, I'll tell you, horizontal lines, they're called as a A line. And you can see the distance between skin and pleural line is equal to pleural line and first A line. The distance between pleural line and first A line is equal to first A line and second A line. So they come at a standardized distance, and they are equidistant. So horizontal, bright or hyperechoic, equidistant reverberation artifacts. So they are A lines. So I think what is A line and how A lines happen, it is clear. So now just look at this image. So again, the soft tissues I'm not going to revise. You can see the pleural line, the brightest structure, and then you see the A lines, horizontal, hyperechoic, equidistant here as well. Okay. So these are A lines. Now you can see here Yeah, so these are the soft tissues. You can see the rib shadows on both sides. The brightest structure is the pleural line, and you can see another hyperechoic horizontal line, that is A line. So this is how A line appears. Now, this is very important. Demonstration of A lines along with lung sliding. I am going to speak about lung sliding. Demonstration of A lines along with lung sliding concludes that lung is normally aerated, and that is what we call it as A profile. So A lines along with lung sliding forms a profile. That's a normal lung. So otherwise, A lines just signal air, but it does not differentiate between whether it is a air in alveoli or whether it is air in a pleura. So if you just see A lines alone on the lung ultrasound, it does not mean that it is a normal lung. This message has to be very clear. So A lines, they just indicate air. It can be alveolar air or pleural air. So far we saw pleural line, we saw A line. Now we will move ahead. This is a fancy term, nothing, I mean, bat wing sign. You, even if you don't remember this, that's okay. This is just a fancy name. So basically pleural line together with two adjacent rib shadows, it forms a bat wing. How? So you can see here, the back of the bat is formed by the bright pleural line, and both the ribs with their black acoustic shadows, they form the wings of the bat. So that is a bat wing sign. So that you need not remember. So pleural line, A line. So 2 points you write it down, pleural line, A line. Now the third one, and very important, lung sliding. Now, as I told you, visceral and parietal pleura, they are normally closely opposed with a minimal fluid in between, and they keep on sliding over one another. This word is very important with every respiration, backwards and forwards. And this movement, this dynamic movement is called as a lung sliding. So they move like this. You can see the movement of my hands. So they slide over one another during the respiration. And this dynamic phenomenon is called as a shimmering line or ant marching. If you're seeing the ants walking in a row as if they walk, you will see it in the ultrasound. So that's why it is called as a simmering line or ant marching. And this is indicative of healthy lung. So this is called as a lung sliding. So how lung sliding appears? Just see here in this video. If you want, I'll pause. So just from top, you can again see nicely the structures, skin, subcutaneous tissue. You can see the pectoralis, you can see the intercostal, you can see the rib shadows, battening sign. The brightest structure is the pleura. And now concentrate. You can see even A lines. I don't want you to see A lines in this video. I just want you to concentrate on the pleura. Now just look at the movement at pleura. Just look at the movement at pleura. Just look at it. And as I told you earlier, I told you like gain is very important. So gain usually you have to reduce to appreciate the lung sliding better way. If you have seen this video properly, I'll play it once again from the beginning. Earlier the gain was more, and once I reduce the gain, the lung sliding is more obvious. So let us play. Now just see, just concentrated pleura. And now the gain is less, and you can see lung sliding nicely. So you can see a shimmering or as if ants are marching. So that is what is lung sliding. So I think it's very clear. It's very clear. Once again, and just, yeah. So you can see now gain is less. See nice movements. Yeah. So that's called as a, sorry, where I was. So that's called as a lung sliding. Again, the another video, you can just see the lung sliding and A lines. Again, longitudinal plane. I just want you to concentrate on the pleura, the brightest structure. You can see lung sliding. Here you can see as if the ants are marching up. Yeah. So nice movement here. Nice movement here. Nice movement here. So that's a lung sliding. So now, what does lung sliding means? Lung sliding means wherever you are doing the scan in that area, pleural surfaces are adjacent to each other. Pleural surface. Please mute all here. Please mute. So in lung sliding, we can see that pleural. What does lung sliding means? The pleural surface are adjacent to each other, and lung volume is changing. So lung sliding indicates. Prashant, can we mute all, please? So lung sliding means that the lung volume is changing, and it is a sign of a dynamicity of the lung. So you can say whenever lung sliding is there, pleural surfaces are adjacent to each other and lung volume is changing. Now, presence of lung sliding along with A lines. This is very important. Presence of lung sliding along with A lines. It defines the alveolar air. So whenever you see lung sliding and you see A lines down, it means that portion of the lung air is there in the alveoli. And what it means, in that particular area, we are looking at the normal lung, and it assures that there is no lung pathology in that particular area we have seen. Say, for example, upper anterior, we are doing it. We have seen a lung sliding, and then we see the equidistant A lines. It means that area of the lung is a normal, healthy lung containing air in alveoli. There is no pathology there. So that's what we call it as a profile. So coming to next sign, that is a seashore sign or a sandy beach sign. It is nothing but the lung sliding on M mode. So what happens here that I'll show you. So once we put a M mode, you will see a echogenic pleural line which divides the image into two parts. The upper part, horizontal upper part, appears as a linear pattern, and it represents the motionless part. It represents the motionless part as if it is a sea, and down the pleural line you can see a grainy or sandy appearance of the structures which appears as a show, and that is a normal to and fro motion of the lung. So let us see how it looks. So again, you can see all the structures, skin, muscle, brightest structure is the pleura, and then rib shadows, and then you put a M mode across the lung, and this is what you're going to get. So skin and muscles, you see the linear pattern. So, and you see the brightest structure on the M mode, that is pleural line. I can
Sir,
see
slides are not
noise in
moving.
the background, please.
Sir, slides are not moving.
Now,
Slides are not visible. It was
now
just stuck on lung sliding. No, not yet.
I actually have moved them. Now,
No, sir, not it.
where it is stuck?
The lung sliding, sir. I
Let
think
me
2 slides before.
here.
No, sir, not
Here.
it.
I can see it nicely. Shall I share it again from where I stopped? Just a minute.
Yes, sir, please.
I think I'll switch off my this thing also. My camera I'll turn off so that it will be better visible, I think. Now tell me what is visible on the screen.
It is still
No,
stuck,
sir.
not moving.
So I need to. I've stopped my camera as well. Now it has
Sir,
come.
you need to stop sharing. Stop sharing and restart sharing again.
Just give me a minute. I have stopped. Now I'm opening this way and I'm sharing. Yeah. Now it is there.
Yes, yes.
Which slide has come now?
Sliding.
Lung sliding.
Have we finished this? I mean,
Yes, sir.
this was clear to you?
Yes, sir.
Yes, sir. Yes,
Yeah.
sir.
I'm moving ahead. Just tell me till what slide we have come. You
The
saw the
next
next
one, sir.
video you couldn't see. And now wait a minute. It will take for me to I mean the slides to jump because I just started. No. take some time once I start sharing for slides to move. Stuck. Give me a minute. My slides are not moving forward now. Just a minute. Okay, anyway, still
Click on the screen. Click on the screen. Okay, and the left corner. Yeah.
now
Yes.
everybody can see the video now.
Yes.
Yeah, I'm playing it. Yeah.
Yes.
All of them have seen video. Shall we go ahead? Shall I skip this?
This video we have finished, sir. From the next slide.
Okay, just a minute. This
No, sir.
This one not, sir.
This is just the A line. This is again just a lung sliding in different modes. That's all. Okay, just constant. Now you can see this video, everybody. Second video.
Yes,
Yes.
sir.
Yeah, now I'll start. Okay, so you can concentrate here. The lung sliding, what I told you, you can see beautifully as if ants are marching up. So the movement, just look at the movement at the pleural line. So that is lung sliding. So we'll just go ahead from here. Now, lung slide. Now slide has come. Just tell me once so that I can move ahead.
Yes.
Yes,
Go
sir.
ahead.
Okay, fine. So what does lung sliding indicates? It indicates that the pleural surfaces are adjacent to each other where we are doing the imaging, and in that zone the volume of lung is changing. So lung sliding is nothing but the dynamicity of the lung. Now lung sliding along with A lines, they indicate alveolar air in the area where we are doing a scanning. So say we are doing a scanning in the upper anterior area. If you see a lung sliding along with equidistant A lines, it means the lung there is containing air in the alveoli, alveolar air, and that part of the lung is a normal lung, and it assures us that there is no pathology in that area of the lung, and that is what we call as A profile. So third point what I want you to write down is a lung sliding, and fourth point is A profile. A profile is nothing but lung slidings along with A lines. So now next, so seashore sign or sandy beach sign, it is nothing but a lung sliding on M mode. So once we put a M mode, we'll see a brightest structure that is a pleura. It is going to divide image into two parts. The upper part appears like a C, that is a horizontal linear pattern caused by soft tissues, which is a motionless part. And the lower part, a part below the pleural line, is it appears like a shore, that is a grainy or sandy appearance. It indicates the normal to and fro motion of the lung. So let us see how it looks. Now see the B mode, normal lung. The brightest structure is the pleura. You have put the M mode and you are going to get this image. Now see here, the brightest structure is the pleural line. Above the pleural line, you are going to see skin and soft tissues like a linear structure. It appears as if it is an ocean or a sea. And down the pleural line, you are going to see a grainy or sandy pattern, what we call it as a sand on the beach or lung artifact. So this is called as a sea shore sign. So sea up, shore down, or a sandy beach appearance. So sea shore sign or a sandy beach appearance. That is nothing but lung sliding on M mode. So again, I'm going to play a video. Just I hope it will be visible. Give me a minute. Yeah. So now you can see here. This is bit a fast video. Yeah. This sorry. It's going next year. Yeah. So I'm going to play a video. You can concentrate. So this part you can see lung sliding nicely again, yeah, and then I have put a M mode across, and then you see a bright pleural line, C and the shower. That is your C shower sign or lung sliding on M mode. So very nicely you can see lung sliding in a B mode as well, and then you see a lung sliding on M mode. So that is a C shower sign. Okay.
Sir, slides are stuck again.
Ayo. I think I should not play videos. Videos I can show you again. This can you see the video now? The blue screen
No,
is
sir.
visible.
No.
Blue
You
screen.
do,
It's
Rahul.
not changing. Blue screen is not
Not
changing.
changing. You do one thing. You can click on the anyway. You have put it on regular presentation mode, na? Don't go to slideshow mode. 49th slide, no. Just click on that slide, na.
Yeah. Okay.
Yeah.
Okay.
Come down. Yeah. Come down. Play. Yeah. It. Play.
Yeah. It's
Yes.
visible.
No.
Yeah.
Okay. Fine.
Now
So
you
just
make it slideshow mode. Yeah. Play now. Yes.
okay. Fine. Or let it be. I'll show you videos later. So basically, same thing I showed. I showed you a lung sliding how it looks in a M mode. Same static image. I showed you a live video. So that's all. So now just all signs we'll see here. Again, the superficial structure. The brightest structure is the pleural line, and then you see the equidistant horizontal A lines. Now this is what we call it as a bat wing sign. And if we put a M mode across, what you are going to see, this slide is visible to all.
Yes.
Yes.
Yeah.
Go ahead.
Yes, sir.
So this, if we put M mode across, what we are going to see is a motionless part above, that is C waves, and down we are going to see the grainy appearance, that is shower. So that is the C shower. So this is a normal lung or A profile, what we have seen. So basically a normal lung or A profile. On B mode, this is called the Merlin space. Forget about this term again. I don't want you to bombard with so many terms. In B mode, you will see the thin pleural line with lung sliding as ants marching. Then you will see equidistant A lines, and you will see no or occasional B lines. I am going to speak what is B lines. I'm just telling you what is a normal lung or A profile. In B mode, you're going to get a thin pleural line, you're going to get equidistant A lines, and occasionally you may see B lines. And on M mode, you're going to see
Rahul. Rahul.
something is wrong. It's on hold.
No. You do one thing. You stop sharing now. So I think you're double clicking on the
Yeah,
screen.
I stopped. I've stopped sharing.
Yeah. You restart sharing now. Don't switch on the video of yours.
Just
If internet there is a problem. No problem. It is very common problem when you're using this. Minimize the Microsoft window. Yeah. It's coming. Yes. So you put it in full screen mode. Okay.
it's a full screen only.
Yeah. We can see. Go ahead now. On the
Okay.
left
So
lower corner, na, you can use that arrows are there.
okay, fine. Rather than touching this thing. Okay. So just to summarize, what is a normal lung or A profile? I already told what is a B mode, and M mode also I have already told. We see the brightest structure as a pleura, and then C on one side and shower on other side. So this is what your normal lung or A profile. So far, uh, So far we have finished. I want you to note down only few points: pleural line, A line, lung sliding, and A profile. So these 4 points are important. That's a normal lung. Now I just want to know you how a normal flaps point appear. This is not a normal sign. I just want you to get acquainted to how a normal flaps point appear. That is nothing but a posterolateral alveolo-pleural syndrome point. As you can see here on the screen, I'm not going to bring my cursor because there is some problem. So as you can see here on the screen, how the probe is placed again at the flaps point. And you can see the orientation marker is facing cranially, and this is how you are going to get this is how you are going to get image on the screen. So basically this is flaps point on right side, this is a liver, this is upper pool of kidney, that's a diaphragm. Lung will come here, and this is a spine. I will show you the video also how normal flaps point look like. You can see here. So this is a flaps point ultrasound on the right side. You can see the structures as well nicely. So that's a liver you can see. Then you can see the upper pool of kidney. Then you can see the diaphragm, the right. Then you can see the spine down here. And then you can see lung. With inspiration, the lung will come into picture. You can see A lines also in the lung. You can see nicely, just see this video. This is how the flaps point appears at right side, a normal flaps point. So liver, upper pore of kidney, spine, diaphragm, and the lung. And if you see properly, you can see, just concentrate on the, sorry, where is the cursor? Not sure. Okay. So you can look at the spine here. The spine, it is ending at the diaphragm. You can't see the spine beyond. Why? Because your lung is filled with air and it is not going to allow waves to cross, and you can't see the spine there. So normal flaps point, you will see that spine is ending at the diaphragm. Okay. So you have a spine from above down, but beyond diaphragm anteriorly, you are not going to see the spine. Now I'm just putting color in the image for a better understanding. Now pay attention. You can see liver again. Now you see the blue line which is coming, that is your pleural line, that is the brightest part. Below blue line, once during inspiration in the lung, you can see equidistant A lines as well. They are green. I have marked them by green. Yeah. You can see a diaphragm which is pink or red, and you can see the spine down which is orange in color. So this is how a normal flaps point. So now we will move ahead. So usually we don't teach diaphragm movement in neonatal ultrasounds, but that is again one of the normal signs which we can see with lung ultrasound. So bedside ultrasound is the fastest method to detect any diaphragmatic paralysis. Now diaphragm, as I just showed you a flaps point, it can be imaged at a flaps point. Ideally, it should be imaged at a phrenic point. I told you where is the phrenic point, but it can be also seen at a flaps point. So either you can do neonatal examination at 10 points, that is 4-point scan on either side and both flaps, or 12 points, that is 4-point scan on either side, 2 flaps and 2 phrenic. So what happens with this, that I'll explain you, like diaphragm will contract towards the probe or upward on the ultrasound image. How it is happening, I'll show you. And you can similarly put a M mode across the diaphragm, and you can even measure the excursion of diaphragm during inspiration and expiration. So whenever there is a diaphragmatic dysfunction during spontaneous respirations, you will see that paralyzed diaphragm will move a little, or it will move in opposite direction. That is a paradoxical. And whenever baby is on a positive pressure ventilation, even if diaphragm is paralyzed, because of a ventilation, the diaphragm is going to get pushed down. In that condition, how you can make out diaphragmatic paralysis is that on affected side, diaphragm will be a normal side. So what you basically have to see, you need to see diaphragm in a B mode you need to see diaphragmatic movements and M mode, and you can calculate the thickness of diaphragm on either side for comparison. Now look at this video, same flaps point. So on B mode, you can see diaphragm as the brightest structure. I think I have put, diaphragm as the brightest structure. Now you can see what happens with breathing. So with inspiration, diaphragm is moving towards the probe. With inspiration, diaphragm is moving towards the probe. So you will see a upward movement on ultrasound image. So it is moving towards the probe, upward movement. That is movement on inspiration, and it will move down. That is towards the lung during expiration. So this is how a diaphragm B mode. Now you put M mode across the diaphragm and you can see the inspiration and expiration. Again, as I told you, the diaphragm will move towards the probe during inspiration. That's why inspiration will come up and expiration will come down on the M mode, and you can measure the excursion as well. So normally in a healthy term pneumon, the movement of diaphragm during inspiration is around 3 to 5 millimeters. So diaphragm moves around 3 to 5 millimeters in a term healthy newborns. So here we have finished all normal lung signs. So again I'm repeating: thin pleural line, A lines equidistant, lung sliding, A profile, and if at all you want to see a diaphragmatic movement. So 5 things you need to see for a normal lung. Now we will go to abnormal lung ultrasound pattern. So pleura does not always work like a mirror. The mirror effect disappears whenever the air content of the lung drops and the fluid accumulates into the lung. As I told you, like alveolar acoustic impedance of the soft tissue and alveoli containing fluid, they are closer to each other. So whenever there is a fluid in the lung, it is not going to reflect back the ultrasound waves. Rather, it will allow ultrasound waves to cross through, and there you are going to get a real image of the lung rather than artifact. So it happens in most of the lung diseases. So most of the lung diseases, you will get a fluid into the lungs, or there will be inflammation into the lungs, which will allow ultrasound beam to cross the pleural lung interface and come down into the lung, and you are going to see the lung structures in a real image rather than artifacts. Okay. Here. I think so. Okay. So I'll move forward. Now, the first abnormal lung ultrasound pattern is absent lung sliding. So I'll show you how absent lung sliding looks like. So first, let us see where all lung sliding will be absent. So whenever pleura are not directly opposed, as I told you earlier, if there is air in between or a fluid in between, you are going to get absent lung sliding. So pneumothorax or pleural effusion. Whenever pleura are stuck together, they are stuck together. It can happen in a pneumonia because of inflammation. It can happen in a ARDS. It can happen in a RDS, or it can happen because of a pleurodosis. So whenever parietal and visceral pleurae are stuck together, lung sliding can be absent. Again, if lung is not there, I mean pneumonectomy is done, or only one lung is getting ventilated, lung sliding will be absent. So for us, whenever there is air or fluid between the pleurae, or whenever pleurae are stuck, as in pneumonia or ARDS or RDS, the lung sliding can be absent. Again, you will see a diminished lung sliding when tidal volumes are very less, when there is a regional hypoventilation, as in obstructive diseases, or if lungs are hyperinflated. So in these conditions also you will see a diminished lung sliding. And very important, why I told that ultrasound beam has to hit perpendicular to the pleural surface is that if you are not holding it properly, if it is tangential, then again your pleural sliding won't be properly visible or will be less visible. So the absent lung sliding. Now just look at this video. Just look at this video. The first part, this video is moving faster. The first part you can see the lung sliding nicely. Now see this part, there is no, this part there is a lung sliding. You can see ant marching. Now this part, there is no lung sliding. It's very clear. It's very clear. I can't pause this video. You just see. Okay, I'm waiting for some time. So now I'll tell you. Yeah. Here you see the lung sliding. Then you move one space, one rib above another area. There is no lung sliding. So this is absent lung sliding. That means there is no sliding movement of the pleury, or there is no ant marching. Okay. So on M mode, I am just going to play this video. I think I'll do same thing. I should minimize and I should play it here. Yeah, it's visible. I'm keeping it like this only. It's visible. I think it is visible.
Yes.
Yeah, I'll play it again. So just concentrate what I'm doing. I'll play it again. Yeah. So now you can see on real image also there is no lung sliding. The pleury are not moving, and then you put M mode and you see something called as a barcode sign. I'll explain that. So how it looks, how the absent lung sliding will look on M mode. So yeah, so you saw in B mode that there won't be a shimmering movement or there won't be a ant marching. That is a absent lung sliding. And when you put a M mode across, you won't see a normal seashore pattern. Rather, you will see horizontal lines everywhere, what we usually call it as a barcode sign in pneumothorax. I'll speak about it in pneumothorax. So this is how absent lung video or absent lung sliding will see on the M mode. So on B mode, there won't be ant marching. On M mode, there won't be seashore line sign. So that is absent lung sliding. So we have finished with the first abnormal sign, that is absent lung sliding. Now I am moving forward. Now
The slides
next
are not going Rahul.
Okay. Which
Just
slide
click.
we are on?
No.
Video
What
only, no?
yeah, that is absent lung sliding video is there. Na video also didn't play. Just click on the video.
Okay.
Click on the screen.
Yeah. Now?
No. Or you minimize.
I have minimized it.
Or stop presentation and restart.
Okay. Stop sharing.
Yeah.
Open share.
Start. Yeah. Share again.
Now it's same.
One second. It's coming. Yeah, it's come now. Okay. Now you play the video. There, I think the best is you play like this. Yeah.
I'll play like this only.
Yeah. Yes.
Will go. Yeah. Yeah. Please concentrate here. On B mode, you can see like there is no ant marching or lung shimmering. And when you put M mode across, you won't see a normal seashore sign. In fact, you can see all the horizontal lines. So this is absent lung sliding in case of pneumothorax. I'll explain you what it is. We call it as a barcode sign. So no shimmering line on B mode and no seashore sign on M mode. Now I will go to slideshow. Now next slide has come.
Yes, sir.
B lines have come.
Yes, sir.
Yeah, okay. So we just saw absent lung sliding. Now next abnormal sign is B lines. So B lines, again, every word is important. They are vertical, linearly, high eco-reflection of a pseudomorphism. I'll explain you what it is. Forget about that. These are vertical, linear, hyperechoic artifacts. So these are short path reverberation artifacts, what we call them as a ring down artifacts in the lungs. Forget about all these names. These are artifacts. They happen when a pulse of ultrasound beam is caught between two reflective surfaces which are very close to each other. So it happens whenever there is a small fluid filled alveolus or whenever there is a fluid in the interlobular septum, that there it is going to happen. How? I will show you now. So second abnormal sign is B lines. They are vertical artifacts and we are going to see how they happen. Now if you see this diagram, sorry. So if you see the ultrasound beam is uh, coming to the pleura, it is crossing pleural line. Down now you have a alveolus which is filled with a fluid, or you have a interlobular septum which is filled with a fluid. So because of the fluid, the ultrasound beam is going to go further, and from the lower edge of the fluid filled alveolus, it will reflect back and it will go back, and what you see on the screen is a first horizontal line. Okay, now what happens when this ultrasound beam is going back? As I told you, like two surfaces which are very close to each other, the the ultrasound beam will get trapped between the upper and lower border of the alveolus. So from upper border of the alveolus, it will again come down, and from here it will again hit up and go to the ultrasound beam, transducer, and you're going to get a second reflection down the first line. And this process can go on and on and on, and like that you're going to get one horizontal reflections down the earlier reflections. And when as it is a fluid filled alveolus, there won't be attenuation of the energy. As it is a fluid filled alveolus, there won't be attenuation of the energy, and this is not going to get fade up, and this will go down till the edge of the screen, and this is what we call it as a B line. Now alveolus is very small, it is hardly around 0.2 mm diameter. So these lines in image here, they're seeing at a distance. Alveolus being too small, this all horizontal lines, they coalesce into one and they form a compact vertical hyperechoic line, and that is what we call it as a B line. So now normally, as I said, like if you remember A profile, I said like there can be occasional B line. So occasional B line can be seen in the normal lungs, and up to two B lines between two rib spaces can be considered as a normal. So in term newborns, we can see them in first 48 hours, or in preterm infants, they may take some more time to disappear. Okay, so this slide is important. So B line has to fulfill all these 7 criteria to call it as a B line. The first one, it is a ring down artifact. Second, it arises from the pleural line. Third, it moves synchronously with lung sliding whenever lung sliding is there. Fourth, it is long and vertical. Fifth, it is well defined and it extends till the edge of the screen. Sixth, it erases A line and it is hyperechoic. So all these 7 points should be there to differentiate B line from any another artifact. So normally, now you can see here, this video is playing.
Yes, sir.
Yeah, now you can see nicely the bright structure is a pleural line, and from pleural line you can see the vertical artifacts. So see, all things are there. They are going down till the edge of screen. They are hyperechoic. They are fading A lines. So these are called as a B lines. So these are B lines. They are long. They are not getting faded. They are going to the edge of screen. They are hyperechoic as pleura. They are abolishing or erasing A line. So this is called as a B line. Okay. So now So now again you can see the B lines here from the pleura. Don't look at the pleura and all, just see the B lines. And if you see here, now here you can see small horizontal frames separately. So that each horizontal frame, usually we call it as a J line. Don't remember this, just remember B lines. So now B lines, okay, now B lines we should distinguish from the some other artifacts, what we call it as a comet tail artifacts or Z lines. Please mute, please, all of you, please mute. So this is called as a, I mean, we need to distinguish B lines from a comet tail artifact or a Z line. So I'll just explain you what is a comet tail artifact. So basically, you get a comet tail artifact whenever there is a fibrous tissue at the pleural lung interface. Suppose this is a fibrous tissue. So what happens whenever the ultrasound beam is going to hit this fibrous tissue, the ultrasound beam is going to get attenuated. And with every returning beam to the transducer, it is going to become weaker and weaker, and then it is going to cause the vertical artifact which fades away quickly. So this is called as a comet tail artifact. So in a fibrous tissue, your ultrasound beam is going to get attenuated. And the second possible cause can be if a ultrasound beam hits two unparalleled surfaces. For example, here you have a transducer and here you have a sphere. So sphere's surface is not plane. So they are unparalleled surfaces. So whenever the ultrasound beam hits, some of the energy will go back to the transducer, but most of it will go off into the other directions. And that's why you'll get a vertical artifact which fades in between. So that is called as a comet tail artifact or Z line. It is usually because of a fibrous tissue at the pleural lung interface or because of a unparalleled surfaces. So how you are going to differentiate? As I told you, comet tail artifacts, there will be less echogenic than pleural line, whereas B lines are equally echoic. Comet tails are ill-defined, B lines are well-defined. Comet tails will vanish soon within 2 to 4 centimeter from pleural line, whereas B lines will go till the edge of screen. Comet tails, they won't erase A lines. You can see A lines through, whereas B lines will erase A lines. And comet tails, they don't move with lung sliding, whereas B lines will move with lung sliding. Now let us see how they appear. You can see this video. Everybody can see this video?
Yes.
Yeah. So just concentrate, it's going a bit faster. You can see the pleural line and here you are going to see the comet tails. Yeah, I'm just pausing. So why I have paused, you can see a pleural line, you can see A lines. So they are not erasing A lines and you can see they're vanishing in between. They're not going till the edge. Yeah, you can see few of them. Yeah, see here. Yes. Yeah, so that's called as a comet tail artifact. Whereas B lines, we already saw how B lines, this is comet tail, how B lines. Now you can see B lines nicely. Just look at B lines, don't look at anything else. So they arise from pleural line. They are going till edge of the screen. They are as bright as a pleural line, hyperechoic, erasing A line. So that's a B line. Moving ahead. So coming to the interstitial syndrome. So interstitial syndrome is actually a sonographic entity where in the conditions where we are going to get a lot of B lines. So most of the disease of the lungs, we are going to get B lines. So it can be localized to one area or it can be everywhere. B lines, they can appear homogeneous or they can appear non-homogeneous. They can be on one side based on the pathology, like unilateral in case of pneumonia, or they can be bilateral in case of pulmonary edema, transient tachypnea, or RDS, or meconium aspiration. So basically, this is nothing but a sonographic entity, and we get it in all common newborn conditions: transient tachypnea, RDS, meconium, BPD. It can be there in the pulmonary edema of cardiac cause, or because of RDS, or any pneumonia as well. So now, so as I told you, in between two ribs, if we see two B lines, that's normal. So whenever we see more than two B lines between the two ribs, we call it as lung rockets. Few people tell like more than three B lines. And when we see five or more B lines, we call it as a ground glass rockets. So basically, to make it simple, if you see more than two B lines between two ribs, it is lung rockets. Now you can see here, this is one rib, this is another rib. 1, 2, 3, 4, 5, 6, almost 6 B lines are there. So whenever you see lung rockets at 4 points on entry chest wall, what I mean by upper anterior, lower anterior, upper lateral, and basal lateral. In each area, if you see lung rockets, that is more than two B lines between two ribs, then it is called as a pulmonary edema. It's as simple as that. Lung rockets as at all 4 areas on the entry chest wall, we call it as a pulmonary edema. Now, I'll just keep this. This is okay. You can distinguish between pulmonary edema of a cardiogenic cause and because of RDS by several other parameters which we are going to discuss further. So I'm skipping this slide. Yeah. So now we are going to see the appearances in certain common neonatal conditions. So far in abnormal signs, we discussed absent lung sliding, B lines, and interstitial syndrome. Okay, 3 points, you write it down. Now most of the conditions what we are going to discuss, there is a lot of overlap, and you can see common findings in most of them. So let us start with the transient tachypnea of newborn. So we know transient tachypnea of newborn is a water in the lungs. So basically we are going to get a B line. So spectrum can be from a total white lung, not white out, white lung, or a prevalent B lines, or a benign pattern where you will see A lines as well. So that is a spectrum. I'll show you all spectrum. The most important thing in TTNB is there won't be any pleural line abnormality. So your pleura will be thin, regular, nice. Okay. So there won't be any pleural line abnormality. Most commonly, you will see the pattern bilaterally, but not always. It can happen at a times that in one lung you will see whiteout, in other lung you may see normal lung, or you may just see few A lines and few B lines. But most of the times it is bilateral. Double lung point, I'll explain you what is double lung point. Double lung point will be seen in milder cases, whereas white lung or a B line pattern is seen in a moderate and severe cases. So I'll tell you what I mean by. So forget about X-ray. So this is ultrasound on the right side of the chest. So here, these are upper lung fields. You can see pleura, it is thin, normal. You can see pleura. So these are upper lung fields where you see a normal lung field. You can see equidistant air lines. So you see a normally aerated lung. And in the lower part of the lung, you can see a lot of B lines. So this is called as a double lung point. That is, upper lung fields are normal, lower lung fields you see a lot of B lines. So in milder cases of TTNB, you get a double lung point. Why does it happen? By default, air will accumulate in the anterior parts, and liquid or fluid will accumulate or gravitate into the posterior parts. So in milder cases, you are going to see a normal lung up and you are going to see fluid down. That's what it is, as simple as that. That is a double lung point. Now, this is how a B profile looks like. Forget about all things, just look at the video. I think it is visible. So you can see multiple B lines going down from the pleural line. So it can be seen in cases of a moderate TTNB. They are not very compact. You can still distinguish them from each another. But there are plenty of B lines and hardly there are any A lines. There are no A lines in fact. Again, in the film, you can see there are multiple B lines. They are not very compact, but there are plenty of B lines. So usually in moderate TTNB, you will get a B line profile. Now you can see here in the video, now you can see compact B lines. There are a lot of compact B lines, and in static film also you can see it is like a white lung. So in severe cases of TTNB, you will see a white lung. So as I told you, both lungs may not be always the same. Now you can see the X-ray of a term baby. It almost looks normal, but we can make like hyperinflated lungs are there. And you can see the ultrasound image on right side where you see the double lung point. So there is a mild TTNB on one side. You can see B lines in the lower lung fields and A lines and a normal lung in upper lung field. Whereas on left side, you can see a lot of B lines. So fluid is bit more in the left lung. So this is how TTNB looks like. So just to summarize TTNB, I am going bit faster. If you feel the speed is more, please tell me. So because we have a lot to finish. So TTNB, very simple. You will see double lung point, mild cases. You will see B line profile in moderate cases, and you will see white lung in severe cases. Why I'm going faster now is you should know the basics and normal things. Abnormal, you can't just remember each and everything. When you do it in a particular case, then you can relate it. Okay. So next we will see pneumothorax. So as Prashant said, you can diagnose pneumothorax in less than 20 seconds, 30 seconds. For beginners, I may say around 1 minute or even 2 minutes. So basically, these are the signs you are going to see in pneumothorax. I am going to explain each of them. So there should be a A- profile. What I mean by A- profile is you won't see any lung sliding. That is, lung sliding is abolished, but you will see A lines. So whenever you see A lines only without any lung sliding, it means that air is in pleura. So that is A dash profile. That's what I said you earlier. A lines alone doesn't tell that it is a normal lung. They just tell like it is a air. So when you see A lines along with lung sliding, that is a A profile. That is a air in alveoli. Whenever you see A lines but you don't see lung sliding, that is A dash profile, and that is a air into pleura. That's very clear. Then you are not going to see any B lines or comet tails. If you see any B lines or comet tails, straight away it is not pneumothorax. Then there is something called the presence of lung point. I'll explain it. And there is an absence of lung pulse, that also I'll explain. So to diagnose a pneumothorax, we follow algorithm. So first you're going to look for lung sliding. If lung sliding is there, it straight away rules out pneumothorax. So lung sliding has 100% negative predictive value for pneumothorax. So it's as simple as that. But it is not that you have to see in only one place. The examination has to be complete. You have to see in all areas. So if there is a lung sliding, it rules out pneumothorax. What I mean by if you see lung sliding in upper anterior area, it means there is no pneumothorax in that area. Suppose you don't see lung sliding, then you look for B lines. If B lines are seen, again it rules out pneumothorax. So irrespective of a lung sliding, if you see B lines, even if lung sliding is absent and you see B lines, that rules out pneumothorax. It is as simple as that. Okay. Next, if you don't see B lines, you need to see for lung point. I'm going to come to that. You need to see lung point, and if you see lung point, it is 100% pneumothorax. So lung point is 100% specific for pneumothorax, and you have to always search for lung point. I mean, absent lung sliding and A lines, they are suggestive of pneumothorax, but they are not specific. Whereas lung point is 100% specific of lung pneumothorax. Now, if you don't see a lung point, you need to see for something called as a lung pulse. I'll explain you what it is. If lung pulse is there, it rules out pneumothorax. If a lung pulse is not there, then it confirms pneumothorax. So we'll see how to go through this algorithm. I will minimize because the video, this screen has come of the video. Screen has come. This slide is there.
Yes.
Yeah, now I'm playing a video. Everybody, please pay attention on B mode and then on M mode and see what's happening. Okay, I think we have seen this video earlier also. So basically, there is no lung sliding, and you can see equidistant A lines. Even in the static image on B mode, this side you can see I'll show that lung sliding is not there, but you can see equidistant A lines. And once we put M mode, how it appears on M mode, this is not seashore sign. This is a barcode sign or stratosphere spine, what we call. And this is pneumothorax. I'll show you. Yeah, just see. So you can see there is no lung sliding in a real B image. I'll play from beginning. Yeah, no lung sliding in real B image, and put M mode, and then you see there is no seashore. This is barcode or stratosphere. So this is pneumothorax. So A dash profile, I told you, it is highly suggestive of a pneumothorax. So first thing you are going to look for lung sliding. If lung sliding is there, it straight away rules out pneumothorax. You don't have to go ahead. So this is how the stratosphere or barcode sign appears on M mode whenever there is a absent lung sliding and A lines are there, pneumothorax. Okay. So first point we saw absent lung sliding with A lines, A dash profile and barcode sign. Now let us see. Now you see this video. I have paid this earlier also. If you concentrate now, see this rib space. This is playing.
Yeah.
Okay, fine. So see the first rib place. You can see the lung sliding there, shimmering, and you go one space above. There is no lung sliding. There is no lung sliding. What else you see? You again concentrate where there is a lung sliding. You can see A lines. Now you see there is no. Sorry, you can see comet tails here along with lung sliding. You can see comet tails where there is no lung sliding. The next part of the video, you can see no comet tails, no B lines. Okay, so basically this is no lung slide and there are no B lines. Okay, so again this suggests a pneumothorax. So if you have a lung sliding, you need to look for B lines. If you don't have a lung sliding, that's clear. Okay, so why I put this video, again you should not just do examination in one area. You can't just tell like you saw lung sliding in one area, comet tails are there, A lines are there, that is a normal lung. You need to screen all areas. Okay. Now coming to the lung point. So as I said, if there is a absent, if there is no lung sliding, next thing you are going to look for whether there are any B lines. So if there is no lung sliding but B lines are seen, that is not pneumothorax. If there are no lung sliding and there are B lines, that is a pneumothorax. But suppose now there is no lung sliding but you see the B lines, then what you have to look for is lung point. So what basically lung point means? It is a transitional zone between normal and abnormal lung. So an area where a lung sliding is there and the area where lung sliding is not there. So lung point is actually a point where both pleural layers are going to join back each other again. So it forms a boundary of pneumothorax. So imagine there is a pneumothorax. So pleura, parietal and visceral pleura are separated in one area. And once you move to another area, the pneumothorax ends there and the pleural surfaces will touch again each other and you are going to see lung sliding there. So that point is called as a lung point. And again, as I told you, air will accumulate anteriorly. So most of the pneumothoraxes will appear on the anterior chest. So to look for the lung point, you need to go more and more laterally. So you have to move your probe from anterior chest to the laterally. And as I said, lung point is 100% specific for pneumothorax. So when you see lung point, there is a pneumothorax. So concentrate on this video. It is visible. I hope it is visible. So just concentrate on this video. Yeah, now see the middle part of the video and look at the pleural line. There is no lung sliding. There is no lung sliding, middle part, no lung sliding. And then you look down, you can see there are A lines as well, and there are no any comet tails in that area. So that is your A dash profile, the middle part, exactly the middle part of the image. Now you look at the peripheral part of the image on both sides, and you can see that lung sliding is appearing, or it looks like a shimmering, or as if ants are marching. And you can see few comet tails arising from the pleural line on both sides of the image. So periphery, you see lung slide and comet tails. So in the center, there is no lung sliding. A lines, no comet tails, that is A dash profile. Periphery, you see lung slide comet tails, and this point is called as a lung point. So even on B mode, you can see lung point nicely. If you're not able to pick it up on B mode, you can put a M mode across and you will see how the lung point appears. So this is how it is going to look on M mode. So basically on one side you have a seashore sign. So that is a normal lung where you have a lung sliding. So this is seashore, that's a normal pleura, and from this point the pleura are separated. There is a air and there is no seashore, and this is barcode. So this point is called as a lung point. Pretty clear? So we have seen the algorithm. First, look for lung sliding. Lung sliding is absent. You go for B lines. B lines are uh, absent. Then you go, B lines are present, that rules out your pneumothorax. If B lines are there, you go and search for lung point. And lung point, if you see, that is 100% specific for your pneumothorax. Now, next. So what is lung pulse? So what happens in the algorithm, if you note, if lung point is there, that's 100% pneumothorax. But if lung point is not there, you have to look for lung pulse. So this is a bit difficult to understand, but I'll tell you. And this video I'll show you later because I need to stop entire presentation. It is not there in the presentation. So lung pulse is nothing but the transmission of cardiac activity through a motionless or near motionless lung. So whenever there is an absent or diminished lung sliding, you can see the transmission of cardiac activity through that portion, and you will see the tiny movement of the visceral pleura along with parietal pleura during cardiac motion. So usually for lung pulse to be visible, that particular area should be near to the heart, and with every heartbeat you are going to see that parietal and visceral pleura are moving. That is not equivalent to lung slide. And actually, to see a lung pulse, if it is really present, then it will be seen nicely on B mode. Most of the times it is difficult to recognize, so it can be recognized very well on M mode, and what we call it on M mode is T lines. I mean, it forms T lines along with the pleural line. I'll show you what I mean by. And as transmission of the heartbeat is required through the lung, whenever there is a air, the transmission won't happen. So in pneumothorax, there won't be lung pulse. So if you see a lung pulse, that is the movement of a visceral and parietal pleura with a cardiac motion, then that rules out pneumothorax. So I'll just show you what I mean by lung pulse. So as I said, it may be difficult to see on real image. B mode. I'll show you how it looks on B mode later on. So you can put a M mode across, and with every cardiac beat, the movements which happen, they form so-called T lines with a pleural line. What I mean by, you just concentrate on this image. Now you have put a M mode across, and for sure there is no seashore sign. That is clear. So it means either lung sliding is absent or it is diminished. So you can see most of the times you can see it is typical horizontal pattern. So there is no shore here. It's not seashore sign. You can see bright pleura. So one thing is clear, that it is absent lung sliding. But whether it is a barcode sign or whether it is a pneumothorax, how you are going to make out, then you have to look for lung pulse or T lines. So if you see that lung pulse or T lines, it means there is a absent lung sliding, but there is no pneumothorax. And how it appears, I'll show you what I meant by. Now you look at these arrows carefully. and look down from the pleural line. You can see the vertical movements. 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 You can see nicely, very nicely, vertical movements. So these are called as a lung pulse. So you can make them out on M mode, and whenever you see absent lung sliding on M mode, look for lung pulse. If you see this lung pulse, it rules out pneumothorax. Very simple. It rules out pneumothorax. It can be some another pathology in which the lung sliding is absent, mostly pneumonia. Okay. So this is what we call as a lung pulse. So now look at this image. This video is playing.
Yes.
Okay, thank you, Prashant. So again, you can see nicely all superficial structures. You see the bright line pleura. Now, first point, there is no lung slide. You concentrate properly. Nice B mode image video. There is no lung sliding. 1 point. Second, look down. Are there any B lines? There are no B lines. You can see there are A lines. So now this is A dash profile. This is A dash profile. Now, can you see any lung point in this? I mean, we have not put M mode, but on B mode also, you can't make out any lung point here. Along the entire pleura, there is no sliding or there is no shimmering. So there is no lung point here. So what you're going to look for here, you're going to look for lung pulse. Now this is not a lung pulse. That's why I said it is usually, unless it is there, it is very difficult to comment whether lung pulse is there or not. If it is there, you can 100% tell that lung pulse is there. But if it is not there, you can't make out, because at a time, because of the movement of chest itself, you may feel that it is a lung pulse. So what you are seeing actually is the movement of chest, or probably probe is moving, but there is no movement of a parietal and visceral pleura along with a cardiac beat. So there is no lung pulse here. But are you sure? So as I said, B mode, it may be difficult. So what we will do now, we will put M mode and we will see what happens. So now here for me on B mode, no lung sliding, no B lines, A lines are seen. There is no lung pulse and there is no lung point also. So if you see lung point, it's 100% pneumothorax. If there is no lung point, you need to look for lung pulse. And if there is no lung pulse, then it is pneumothorax. If lung pulse is there, it is not pneumothorax. So put M mode here and see what happens. Now this is what is happening here. Now you can see there are no T lines. It's very clear. There are no T lines. There are no T lines. There are no T lines. What I mean by there is no lung pulse. It is a typical barcode sign, and this is a pneumothorax. So this is how you diagnose a pneumothorax. I'll just brief it. So pneumothorax, I think we need to rush. So pneumothorax, look for lung sliding. Lung sliding is there. Pneumothorax is ruled out. Lung sliding is absent. Look for B lines. B lines are there. Pneumothorax is ruled out. No B lines. Look for lung point. Lung point is there. Pneumothorax is confirmed. Don't go ahead. If there is no lung point, look for lung pulse. Lung pulse is there. Pneumothorax is ruled out. Very clear? Okay. So we saw B lines, interstitial syndrome. We saw TTNB. We saw pneumothorax. Now alveolar syndrome. What I mean by alveolar syndrome, anything which affects alveoli is alveolar syndrome. So it can be either consolidation or atelectasis. So whenever there is a collapse of alveoli, whenever alveoli are fluid filled, whenever there is inflammation of alveoli, that all forms your alveolar syndrome. So consolidation, MAS, BPD, atelectasis, collapse, everything is a alveolar syndrome, and there will be a lot of overlap in the symptoms. So we'll just see the specific symptoms. So lung consolidation or pneumonia. So as I told you, consolidation are highly fluid filled. So most of the times they'll reach the pleura and they can be directly seen. So what I mean by they touch the pleura, the ultrasound waves are going to go across and you can see lung consolidations actually in real. So what are the ultrasound patterns? It can be anterior consolidation. I'll show you all the images. I'm just rushing through the list. Anterior consolidation. It can be tissue-like sign, it can be shred sign, it can be air fluid bronchograms, it can be increased vascularity on Doppler, or it can be presence of lung pulse, what we just discussed. Okay, so it can be combination of one or two or all of them. So this is how lung consolidation is going to happen. Now, the first thing what you see is the anterior consolidation. So as I told, most of the pneumonias, they'll reach the pleural surface and they can be directly seen. So what I mean by, you can see the pleural line, and down there you can see the consolidation, around anterior consolidation, which will appear like echogenic structures, and down you will see a lot of B lines. I mean, there's a lot of fluid in the lungs. So this is how classic, I'm just showing you image. It's very clear how anterior consolidation looks like. Down the pleura, you will see the consolidation. So second sign is a hypatination of the lung or a tissue sign. So basically what happens, we have learned in the pathology as well. In gross pathology, we have seen the specimens. So in consolidation, lung will become like a liver. So that's why it is called as a hypatination of the lung, or it will look like a tissue. It will look like a liver. So this is ultrasound at flaps point. You can see very nicely. There's a liver here. There is a diaphragm, and this lung is looking like a liver. So this is what we call it as a hypatination of the lung. So normal lung, you are not going to see a tissue-like consistency here. I have already shown you a normal flaps point. There you are going to see, this is a pleural line. Actually, there is minimal effusion also. I'll speak about that. So normally you are going to see a pleural line, and you may see A lines, but you won't see a tissue-like consistency. That's called as a hypatination of the lung. Now, third sign is a shred sign. So what shred sign means, when consolidations are not extensive, they will look as if you have removed the pieces of the lung. So it will appear as a echo-poor area. I'll show you the image how it looks like. So it will just look like a punched out lung. So echo-poor area, and this area will be surrounded by a normally aerated lungs, and you may see some comet tails in that, or normal lung, whatever it is. So at the border of this consolidation and a normal lung, this border won't be sharp, and this border appears as a irregular hyperechogenic regions, and that are called as a shred sign or a fractal sign. So I'll just explain you quickly in the image. So look at this image. This is a flaps point on left side. Where is my cursor? It's missing. किधर गया यार? पता नहीं. ठीक है. So you see a spleen, you see a diaphragm. Yeah, it has come. This is spleen. You see a diaphragm. You see a superficial structures. This is a pleural line or a parietal pleura. There is some effusion. I'll tell you how effusion looks like. And this is a lung. Normally what you expect in a lung, you expect A lines, but there are no A lines. This part of the lung, it looks tissue-like, or it looks like less echoic. So it looks like a punched out area, and there is a normal lung down, this border of the normal aerated lung, and this punched out or low echogenic area, you see hyperechoic lesions. So these are called as a shred sign or a fractal sign. You can see some comet tails or B lines down. So this is a shred sign. So look at this video. This video is playing.
Yes.
Okay, so you can see nicely the superficial structures. You can see there is a effusion. I'll explain how effusion looks like. You can see a echo-poor area as if it is the lung pieces are removed, and at the border of a normal lung and this echo-poor area, you see this shred signs. You see this shred sign or a fractal sign. So this is a shred sign. So next, what you see in pneumonias or consolidation is you see air and fluid bronchograms. So air bronchograms, they will appear white, whereas fluid bronchograms will appear black. They can be punctiform if they are transferred to the ultrasound beam, and they will be linear if they are along the beam. So fluid bronchograms are specific of pneumonia. Whenever you see fluid bronchograms, it is pneumonia. you close the eyes. And dynamic air bronchograms, what I mean by there, during inspiration, you can see the centrifugal movement. I mean, there will be movement outside, and with expiration, there will be movements towards the lung. They are specific of consolidation. So you'll see dynamic air bronchograms in consolidation, whereas static air bronchograms, there won't be any movement. You will see in atelectasis. I'll show you all this. Okay. So just the static images. So first image, you see the punctate or punctiform air bronchograms as they are in the transverse plane to the beam. And here you see the linear bronchogram with branching. Air bronchogram it is, as they are wide, they are air bronchograms. Okay, as it is longitudinal to the beam. Now look at this video carefully. Look at this video carefully. So again, this is flaps on right side. You have a lever, you have a diaphragm. There is a minimal effusion above. You can see a thread sign. You can see a thread sign. And now even you can see the tissue-like consistency, that is consolidation. And now you look at the movement here. You concentrate at the movement here. With inspiration, what's happening? You can see the white expression. So it's very clear. It's very clear. You can see nicely. You can see nicely. So, and that's what we call it as a dynamic air bronchogram. So you see with inspiration, they are coming towards the lung. Sorry, with inspiration, they are going away from the lung. Now inspiration, and with expiration, they are coming towards the lung. Inspiration away, expiration towards. So this is called as a dynamic air bronchogram. So whenever dynamic air bronchogram is there, it is consolidation. Now look at this video. Now look at this video. Again, this is a flaps point. You have a lever here. You have some effusion here. You have a thread sign. You have a tissue-like consistency or hypatinization. And now you see what's happening with inspiration. You can see dynamic air bronchograms. Dynamic air bronchograms. And what else you see here that is very classic of pneumonia is a fluid bronchogram. So whenever a black is a fluid bronchogram.
Rahul? Rahul?
Shall I share?
We are in just few seconds back. We stopped hearing you. I can hear you now.
Just a minute. I'll start sharing again.
Yeah.
Yeah. It's visible.
Yeah. It's visible.
Did we finish a fluid bronchogram?
Yes. Go ahead.
Yeah. So I'll share it. Yeah, we saw fluid bronchogram just now. I wanted to tell you something else there in that video itself. Yeah. Okay, so we were talking about this. So fluid bronchogram. Now, the effusion are being.
Rahul?
Yeah.
Rahul, there are a lot of many more things are there in the lung, and we have to show in the this thing also. What is it? Virtually also we have to show. I think so. We will hold in case if you are willing, we can hold next Tuesday. We will finish the thing.
Okay.
Next
Shall
Tuesday
we
because
finish till pneumonia?
no, because people have to go for the job or something. No.
Okay, fine. So we'll do remaining
Because
things later.
next Tuesday you can continue pneumonia number one.
Okay.
How to assess the maximum PEEP in the lung ultrasound.
Hmm.
How much to keep in a neonate or pediatric or adult? How much to keep? How it is number one. Second thing is not only that. Other things are there. There are so many other things are there. No, you can go ahead and do in the next 1 hour.
Okay.
Then another 1 hour, all the things you can show it in the live demo virtual, because otherwise without virtual demo, so it is incomplete. Teaching is incomplete. Next Tuesday we can finalize it. Is it okay with you, dear?
Yeah, that's fine. That's fine.
Yeah, I think so. You can if you don't mind, you can hand over to Prashant. So Prashant will talk and finish and hand over to Kamal sir.
Yes, sir. Okay.
Just a minute.
So we can join next Tuesday, sir. And Prashant, sir.
Yes, sir. Yes, sir. Yes, sir.
So we have completed till
We'll start from pneumonia.
pneumonia. Okay, sir. Okay, sir.
4:15. Hands-on we'll do in the next class, sir. Dinakar, sir.
That should be fine. Last time it would. Next time
hands-on we will do. Don't worry, Rahul. Next also you continue. Okay, hands-on also you can show them. I'll be there anyhow. Okay.
Okay.
So till 4:30 and we can finish next class. We can show everything, whatever the doubts the people are having. Because first class 81 people have attended. So today is the last class. I thought today also 81 people have attended. Anyhow, we are postponing to the next Tuesday. If Kamal sir is okay.
Oh yes, definitely, sir. This is a gift. We have to grab it. One more class is excellent for us.
Okay, sir. Thank you.
Yeah.
Sir. No problem.
Yeah. Sure. Definitely, sir. Thank you. Thank you so much, sir. We will continue then now next Tuesday, sir.
Yeah.
No.
Thank you, sir. Thank you, sir. Rahul, thank you. Thank you.
Okay.
It was very excellent. So many points you clearly showed us. Now I think we do the virtual thing, it will fall in place. Thank you so much.